Welcome everyone. Let's kick off. Apologies for being a couple of minutes late. So, welcome to the Integrated Care Board for Cornwall and the Isles of Scilly. We've got, let's just see, quite a few apologies. I'll just go through those first of all. We've got Chris, who has gone to I think, is it a regional or national?
It's regional today. It was
regional CMO meeting. Kate's on holiday, so Susan is deputising as Chief Executive. We have apologies from Neil Lenton, Neil, one of our non-execs, Stuart, Ali Woolman, and Andy Sant, and I believe Kelvin will be slightly late. Is there anybody else you think I've missed? No? Okay, so I'll probably be saying this twice today, but we've got a couple of things I just need to sort of say as I do an intro. The first is we have a new colleague formally in Nick. You've been with us in a different capacity, but yes. Today's your first role as an other statutory member. I'm sure the House of Parliament probably could have come up with a better title than other member. But
I've been called worse, Chair.
That's right. But effectively, again, just so everyone's really clear, is acting in the capacity as a non-exec, except that you are acting in this instance because you have other interests in an other member role, but it has all the same responsibilities and duties. It's just got a slightly different badge. So welcome.
Great to be here. Thank you for being part of the journey. Looking forward to it. Thank you very much.
And of course, the opportunity for you to start came about because this is Carol's last board meeting. So Carol, I just wanted to reach out and say thank you for everything you've done. You've been with us pre the Integrated Care Board, actually. We actually started, I think, was it February as a group together? So you've been on a slightly longer journey than probably people give credit. So you've made a huge impact, which we've all been very grateful for, sincerely. And we just wish you all the well and the best. And thank you for everything you do for us.
Likewise, thank you, everyone. Thank you.
Before I get into the meat of the meeting and that, I just wanted to, I've been sort of doing some sort of reflections. Sometimes, I don't know whether you do, but I wake up midway through the night on occasions, and I did last night, and I was thinking about what would make me go to sleep. So I thought, I know, I'm actually going to read the Nolan Principles. I'm going to look up what unitary board means and a few things like that, which is quite an interesting piece of work. I thought that would send me to sleep, but I was still awake at 4, so clearly they're more riveting than you think. The reason why I say that is that as a unitary team, we're going to have challenges. We're going to have to meet those challenges together. And I would like to encourage people to be what they say in those principles, honest, with integrity. I'd like people to do things from a position of accountability, but also from a position of leadership. Because we are the leadership cohort here across the system. And there'll be things as we go through the day that I would just encourage you to think about how we can do things well and better. And there will be issues that we will discuss that will cause us to think about what are we doing? Is it all working? Can we do this better? And we need to do that from a citizen patient perspective. And actually, as long as we put that first, and I know every one of you will do that, but I'm just asking you to think about, as we go through the variety of papers, both this morning and this afternoon, how we go about doing that. I'd be very grateful. Okay, thank you. So declarations of interest. I'm noting them. Are there any declarations of interest pertinent to the agenda that you want me to raise? No? Okay, thank you. I haven't received any questions from the public, so I'm going to press on. So if I can move to the minutes of the 11th of January, are you happy for me to sign those as an accurate reflection of the meeting? Yeah?
Yeah.
Okay, thank you. Now, usually I sort of just turn to the actions and assume most of them have been taken as part of the agenda, but I do think it's important, Molly, we just go back over the action log and formally clear some of these and bring some of the others up to date. So can you lead us, Molly, through the part 1 action log and see which matters that we can close and which ones you think we need to update and bring forward? Can't hear you, Molly. No.
My fault, John. Bear with me a second.
Okay, it's our end, Molly. Bear with you. It's our end. Yep, can you talk? Molly, do try. Yeah, if you can turn the volume up, Pete, I'd be grateful. Yeah, no, we can just about hear you. We need to really hear you. So
Can't hear you. Can't hear you.
sort the technology. Sorry. Shall I come back, Pete? Yeah, so let me come back to the actions. Apologies, everyone, but I also need to ensure, Pete, I'm sure this isn't just going to be Molly then, it's anyone who's on the call. So, yeah. Yeah, okay. So I'm going to move on to the health and care vignettes. So Lucy called me last night and said, John, I'm going to let you down. I'm going to go and meet the Prime Minister. I thought, why? Why not come to our board? What's more interesting? But she is, I believe, in Newquay at the moment, doing an activity on dental support for some announcements that are being made on dental. So you've got me really to try and cover off the vignettes. So I'm going to lead the discussion on here. So having looked at them, does anyone want, before I make my observations, anyone want to reflect on the vignettes?
Yes, John. I mean, obviously there was I don't know if it was deliberate, but a bit of a focus on care in the home, I suppose, or care closer to home. And it was really good, well, personally for me anyway, to see how some of that hospital at home, virtual ward stuff is actually working for people in reality. And actually really great to see. I know from the performance report, we actually increased quite substantially the amount of care we're providing in that way. And definitely coming across in the vignette it's working and people are enjoying it. So it's good to see.
Okay. Any other commentary on it? I think it was a good balance of, yes, Debbie.
On from Martin that it's just a small additional point, but one of our acute GPs was in the emergency department supporting RCHT recently, and they saw a patient who actually said, "Can I please go home on the virtual ward?" So actually, I do think the comms are really important, not just to assure ourselves that we've got a range of different offerings at care at home, but that we're also updating the public and also providing greater confidence and assurance to them. Unfortunately, that particular gentleman did have a requirement, a clinical requirement, to be in hospital for a few days, but he was nevertheless advised that that would, potentially be an option for him if it was safe to do for him at the end of his needed hospital stay. We also had a fantastic 2-page spread in the West Briton, which was very much written as a question and answer or frequently answered questions. And again, that has provided some fantastic resident feedback in terms of, in a sense, demystifying what does this all mean, because most people think of it as not being human or clinician led when actually it is. So the more we can do to continue to raise awareness, the better. So I'm very grateful for the vignette and Martin's comment.
Yeah, agreed. And I have to say, the one that stood out for me on top of that, one was, I love looking at the Women and Children Hospital update film, but the Community Hubs Explainer, trying to understand not just what they were, but actually the scale of support. I think we sometimes completely underestimate the scale of interventions that we actually are delivering. So I thought that was another good update for us on that. Yes, Carol?
I just on that one point, I'd be interested if there's some tracking about the 10,000 that were signposted on.
Okay.
Because there's a huge possibility that they're signed on within the community in the third sector, and actually there's a pressure then there
Okay.
And I know we're obviously going to be talking about financial pressures later.
Pressure everywhere.
Exactly. But it's about understanding that rather than celebrating 10,000 were signpost on. Where are they being signpost on? Because I know from my day job, we get a lot of signposts, and that's creating an extra workload. So it's just about having sight of it as opposed to just celebrating the numbers.
Just at a personal level, I just want to sort of completely support the observation around the MIUs in Bob's story. I have to say, from a personal experience, everyone I've been to too many in Cornwall, unfortunately, but with the family or friends or whatever, they've always been excellent. So you want to add something?
So I was just going to pick up on exactly the same thing. So I very recently with my mum had an experience through 111 online and then the MIUs. And I have to say, in and out in 2.5 hours, the whole process from 111 to coming home. And the staff there at Liscard were amazing. We were supposed to be going to Bodmin, but Bodmin very kindly phoned us before we got in the car to say, actually, if you go to Liscard, you'll be seen so much quicker. So it was just like having it working in the world that we do, where it all feels very, very chaotic and it's not working. I have to say the experience was great.
But Debbie and Margaret, can I just ask, do you still feel they're a bit of a hidden jewel?
Yes, definitely. Yes, and I think also, you know, if you look at the activity data and the performance data, and apologies, Steve, but I think it is important to celebrate the contribution that the minor injuries units make to the overall system 4-hour target. So in any one day, we can see 2/3 of the urgent and emergency care activity across the county. We know that there's more we could and can do, but that is all requiring staff. And we know that that's qualified staff working in environments that are not medically led do need to be well planned for. But I think we work fantastically well. The other thing is that we work fantastically well with RCHT because they provide most of the diagnostic support by way of X-ray, and we know that that's an important component of keeping people out, as well as UHP.
Right, thank you very much. Sanj.
Yeah, definitely would second it. I also had an experience with MIU in St Austell, and it was very good. Within 15 minutes triage, and then being seen within 45 minutes. And it was very quiet. There was only one other person waiting. So, you know, I went through the 1 route and was correctly referred there. So, you know, I do think it's a hidden jewel because it was a Saturday. I thought it would be busier, and it wasn't. And it was much quicker than if what would have been incorrect if I turned up at RCHT, which wasn't what I needed, and 111 were correctly referring me there.
Okay, well done. Thank you very much. Okay, so let's move.
The praise on to our MIU staff.
So you need to, thank you, please, thank you. Pete, are we now able to go back to Molly? Molly, can you talk so we can hear, please?
Thank you, Chair. Can you hear me now?
Oh, that's so much better. Thank you so much. Right, action log, and what can we close and what's outstanding, and we need a bit of a refresh on it, please.
Thank you, Chair. So if it's okay with you, I'm just going to highlight the items that are suggested to close for the meeting. So the first one is item 3 on the basis that it's on the agenda and that it's incorporated within that paper. And the next one after that, item 3, is in relation to the deep dive. And sorry, that was the first one. The second one is about the extraordinary board. Again, it's underway to sign with the dates with RCHT and CFT. I have a draft date that we're working on at the moment. So that's item 4. And then we also have a streamlined agenda for February. Again, that's been agreed. For the ENIA finance, that's in part 2. And then we've got quite a few items, Chair, that are now on the forward plan. So on that basis, we're suggesting that they're closed. And I'll just briefly summarise what they are. The first one is about the environmental update and dentistry. And then there's also an item on prescribing that's on the forward plan, which is attached as an agenda item on its own. And then we get into the detail around the healthcare, the vignette, and that item has been deferred until June. So I'll suggest it's closed because it's in the cycle of business for June. And then there's an action in relation to the IPR, which is about cancer performance, and that's noted on the forward agenda.
Molly, you've muted yourself somehow.
Apologies, John.
No.
Would you like me to repeat from the last item? So that was around pharmacy, and we're suggesting the item is closed because this is not currently possible to have pharmacy metrics within the IPR. And then there is item 6 on the December board meeting, which is about committee and partner updates. So again, this is complete. We've incorporated regular updates in there as set out in the document. And similarly, item 7 is also complete on the basis that there's been an extensive publicity campaign to primary care networks on winter. And also around contact with ICA managing directors, that's also being submitted for closure. And then the constitution update in relation to actions from the last meeting, that has been updated and published. And there's a second item as well, which has also been updated. So those are the actions, Chair, that I'm proposing that we close. And then there are some open actions, and I'm just going to invite Susan to give us an update on the Sexual Health Charter, which is item 14 and 15.
Thank you, Molly. So the action that we had were around the numbers of incidents reported anonymously through staff survey, and they should be reflective of the number of incidents reported to the ICB. I think if both lines of data correspond, then it suggests a positive indicator that staff feel able to speak up, which is incredibly important, and report any sexual safety incidents. When the number of incidents reported honestly through the staff survey is significantly greater than the number reported in the ICB, this could indicate the ICB needs to take steps to understand why there is a disparity. So I think that closes the action, and it's something that we continue to monitor and will do.
Okay. Sanj?
Just a note on the forward plan. If you look at March, it looks pretty ambitious, given that we'll also be doing budget sign off. So can I just put that as a note that some of these may need to be bumped, and that therefore we consider that accordingly. It's also the knock on for my committee, the FPCC, in terms of spending a good chunk of the next one on budget as well. And there's a few things added to that in the forward plan as well. So
Okay. Okay. We'll come back to that when we come to the forward plan, if that's all right, Sanj. Keep going, Molly.
Thank you, Chair. So apologies, due to the small print on my document, I omitted to mention on the winter plan. So there's item 11 just directly above the mortality action. We have trained logists within the ICB and are currently looking at options to offer system-wide training. So it's more of an ongoing action. So I'm not proposing to close this at this point in time.
Keep going.
And there are some other actions as well from November where we're suggesting we close the first action pertaining to the vignettes as well. And this is about the Kerner young carers, and we've got some data there that's included. So if the board is content, we'll close the item. And then we've got some other updates which are enclosed from actions 5 to 14 below, 2 of which are updates. And I suggest that we would consider the IPR, and if we're content, we can close those actions because they're reliant upon the board being assured about the content of the IPR. And then the last 2 items in December are relating to elective deep dive, which was received by the FPCC in November. And there's a risk register action which is still open. So, Chair, you recall from last meeting we spoke about devising a risk register for the winter plan. We're proposing to complete that action in March in time for us to review and revise our risk ratings for our corporate risk register and BAF refresh. So that's December. Sorry, November, apologies. And then there's also quite a few actions. So I believe there are 4 actions which are also highlighted on annual public health reporting. There's 2 of those which we're proposing to close, as well as the mental health ones, on the basis that we've resolved the query around the outcomes approach for the first one, and prioritization and benchmarking tools, narrative contained there as well. And then lastly, there are 2 actions in October which are closed, which are in relation to mental health workforce, and also an action for the council in relation to specialist housing, because the information was sent to Debbie Richards. So I'm just going to pause there, Chair. I think that's covered the actions which are closed or where ABD is available.
Okay, it was important to refresh it. Rachel?
Sorry, just a point on the action which is under the November month around the integrated performance report, because the suggestion is that, because I think we've raised a number of times that whilst it's very comprehensive, it doesn't really include primary and community metrics. So we're suggesting we close that as an action because the soft metrics are included. So if it is the board's will that everything is just the soft metrics, then I would think that was reasonable. But I think if we're talking about a more systems view, then we might want to continue to look at what are the right metrics for primary care and community in the integrated performance report.
I'd agree with that, and we certainly through the journey that we've travelled with our IPR, we are trying to refine some of those metrics in partnership with primary care colleagues. So I would agree with you, but I still want to continue that work, because what we end up with, and it was something that was noted in our finance and performance committee, is much of the metrics then focus on either NHS 111 or RCHT. So what you don't get then is a full view of system performance, and that's really important. And it's also important because we need to know where to target our solutions, particularly during winter, to try and manage the flow that we see through our acute trust.
Okay, Molly, are we done on actions? Yeah.
Yes, thank you, Chair.
Lovely. Thank you very much. Okay, colleagues, let's move on. We've done the health and care vignettes, so the chair's update. So I'm going to take it as read. Just to point out, I know Russell isn't here, but I do want to formally welcome Russell, even though he's not here, who's the new Chief Executive of the Council for Isles of Scilly. He is now in place. And we're hoping that from next month, Steve Moore, who is going to be the Chief Executive of Devon ICB, once he starts, he'll be joining us as well. And of course, he'll be taking over from Jane. So just to bring that to your light. And I guess the only point that might be worth just having an update on is, even since the update at the back of my pack on dentistry, Prime Minister's chosen to trump my board report, which is fine. But there's quite a lot that might come Cornwall and Isles of Scilly way on the back of that. So is there anything you want to add?
Only that, as we know, the guidance came out, we received it at 4 p.m. yesterday. I think we've reported to board once on one of our papers about the work that we've been doing specifically with the Lostwithiel practice around people who have been unable to get to dental appointments for one reason or another. And we would look to some of that money that's being released to extend that pilot into other areas. Other things that are already under development, which this will help, of course, is we have established the dental strategy clinical lead for Cornwall and the Isles of Scilly, which is in line with what's happening nationally, and the increase of the units of dental activity and units of orthodontic activity values to achieve a more standardised approach across Cornwall, because we know that we've got disparity across our county. And it's really looking to welcome the addition of current and proposed programmes to recover some of that dental work, but also to stabilise the workforce. So we've got a lot of work to do. As I say, the announcement was late. I think Lucy's got a comms pack that will go out later today to support some of the work. And I suggest that I propose that we bring back a paper to board chair on the work that's being done in answer to this latest guidance.
Do you have a view as to how, bearing in mind there was stuff still being announced in the House
Yeah.
only yesterday, when do you think that might
I'd
start to land?
Could I suggest a couple of months before we bring something back?
Yep. Yeah, so Tan first and then Debbie.
That's great news. My only challenge, I suppose, is that we can make sure that we ensure that there's a proper assessment in terms of places of most need, and particularly in terms of the core 20, but also some of those priority groups. One of the things that I see in my day job time and time again, people with learning difficulties or disabilities.
Which is the
and their
board's,
teeth
who is the
carers.
board sponsor for dental?
Chris.
Chris. Thank you. Debbie?
So and I think, sorry, just on that point, I think having a dental clinical lead for the ICB is going to be a really positive move to do exactly that. And I know Chris has been talking about that recently.
Very good. Thank you. Debbie?
So thank you for that. And I think we all welcome the news, don't we? And this is going to be a multi-year plan in terms of improving access. It just strikes me in my out and abouts that one of my community hospitals has actually got a dental area that's not used. It was used prior to COVID. It's not been brought back into use. So clearly, as I don't commission dental services, but it seems to be quite a shame. So I can't comment on the quality of the equipment or the build, but workforce is one thing, but also facilities and access to those facilities is another. And if we have got fallow dental clinic rooms, and I can't comment, as I say, on whether they meet current standards, but if we've got them existing and they're not in use, then I think we should include at least a scoping of those, Susan, as part of that work.
As I said, I think we need that dental strategy to also take into account our estates, but also what we do with people at home, in that sort of to try and prevent some of the issues. And I know Rachel and the team have been doing a lot of work around that.
I have to just say, I think NHSE regional and national teams have been really quite progressive in terms of trying to get this agenda raised and pushed forward. So thank you, Rachel, to you and your colleagues on that. Okay, happy with that? Anything else on my report? No? Okay, so we're into the CEO report. So Susan, over to you, please.
Thank you, Chair. Again, I'll take the report as read. I would just like to, I think we've touched on some of this, the amount of work that's happening and activity that's happening within community and at place is great. Some of the numbers are high, and Carol, you're right to point out, are we just shifting pressure from one area to another? And it's a really good point for us to be cognizant about, and how we manage that within place is incredibly important. But notwithstanding, the community hubs are seeing a huge amount of people coming through them, and positively reporting back. Just wanted to also to give a bit of a mention to the Women's Health Hub. Again, some more financial support that came down nationally, and the work that we're doing has been picked up. Kate, it's a shame Kate's not here, because I know she's chaired those meetings, and we're starting to see a real groundswell of support. So that work and that focus of what we do within our place and at community, I think has been phenomenal.
So thank you. So on that point, I've been in contact with Dame Leslie Regan, who's leading the country's women's strategy, and she's agreed to come to one of our board meetings.
Oh, fantastic.
So if you could, I've touched base with Caroline, all we've got to do is work out what date that she can make and you feel is appropriate. Because I think having something like Dame Leslie here sharing us what's going on, and then showcasing maybe what we're doing too in that might be really important.
I just wonder if we could get some more information on what's it gonna, is it going to be virtual, is it going to be a physical, what services are going to be provided, who's going to provide, and just, it's really exciting, and I'd just like to know.
So can I, without overloading our agenda, I think just as we've had, I think there's two meetings that we've had, it might be it'd be helpful to bring a paper along to describe the work that's being done.
Excellent, thank you. Or, anything you've got background reading, I think we'd be happy to see.
Either or those two items, it's got to be both to make it work in terms of the virtual and physical. So
I think it's very exciting, and I'm just been spending just thinking about how we can provide the services.
Yeah,
Yeah,
it's
there is.
crucial.
Absolutely. And the only other point that I was going to make, Chair, was of course we've had critical incident during January, very difficult time. We took I think it was 10 days to come out of it. Just want to say thank you to all of our teams, very hard work to de-escalate out a critical incident. And we were by no means the only system that found themselves in that position during January. So just to acknowledge the work that went on amongst our teams to get out and the lessons that are learned. We are still collating responses back from our providers and wider system, which we will then take through a tabletop exercise and bring back as an update paper and lessons learned as part of the wider winter plan.
And the winter plan was always going to be an iterative learning document plan. So it's important that we get the learnings on that pretty quickly. Debbie?
Yeah, so 2 points. One on the critical incident. So as the community provider, not only were we in the Cornwall critical incident and supporting, but almost in parallel, Derriford declared a critical incident. And so we were also facing into that part of the Devon system to absolutely ensure that we could bring back to Cornwall those from the north and east that required care closer to home. So there are times when it becomes quite challenging for the community provider to be facing in two directions. And I'm just really grateful for the collaborative spirit that we have managed to achieve actually over working together to support those over the border as well. The second thing is a very separate point, Chair, and Susan and I spoke earlier in the week, but just by way of an update on the Isles of Scilly. So we've had positive feedback from the regional team with no substantial amendments to the business case. So that will shortly be we'll shortly be providing a little bit of additional information and clarity, so nothing that needs to come back here, and that will progress to the Department of Health. However, we have hit a technical glitch on the grant position, and colleagues will recall that we had to, as an ICB, sign the letter of support, and Simon quite rightly pointed out that we needed to be explicit about the grant position, and that's now been escalated to the national team for resolution. At the present moment, we have not impacted on the critical path, and I am assured that it will not impact on the critical path, but I didn't want to come here next month not having flagged this as a risk that is greater than was reported through to the last board, Chair.
Okay, thank you. Steve?
Yeah, I echo Susan's comments about the critical incident and the work of colleagues right across the system. It was an exceptionally challenged time. But just to observe as well, John, that even though we've de-escalated from critical incident, the level of pressure across the system continues to be extreme. RCHT continues to be at an Opal 4 position for significant periods of time. So we shouldn't underestimate the ongoing level of challenge, even outside of critical incident, that our system faces. And we continue at times to see long ambulance handover delays, long waits in the emergency department, and all parts of our health and care system under very significant pressure.
Yes.
Thank you. So just before I move on, Steve, I want to build on that, because one thing that I think we're all experiencing is that it's quite fast moving, a lot of this, and changing. And therefore, as we learn from these changes, what are working and what aren't, I think we need to collectively understand what's working and collectively understand what's not, and act swiftly where we can to rework if need be. So maybe as the morning and the day goes on, we can pick up potentially either under the IPR report, or more likely under the winter planning document, quite what that looks like, and how we actually want to be fleet of foot to, because we're still in winter. We are when I put my coat on this morning anyway. It's okay. Okay. Yeah, not where I live, Carol. Okay, so thank you. So let's move on to the integrated performance report. Now, Susan, there's a lot in here. Okay, so what I'm going to ask, because I would rather probably have a bit of a quality discussion on the winter plan, which can cover a lot of this off. You've all had the chance to read this. There is a lot of great data in here, but there's still a lot of it. I still think we could possibly work a bit on summarising some of this for greater impact here. But is there anything you want to do to introduce this? Because I will then touch on workforce and finance with Patrick and Simon, but on the bits to do with performance, community weights in mental health and quality. Do you want to wrap that up as a high level summary?
Yep, happy to do that, Chair. Thank you. And as always, just to note that our IPR is the majority of the data is taken from November. So it's November's data that we're using, which has been validated. And as we know, and as Steve has outlined, we remain in Opal 4, our trust remains in Opal 4. So, and the system is under huge pressure. So this is always a retrospective look and should be taken as such. So overall, we've seen some decline in our system oversight framework metrics. We have seen some improvements, but overall we've seen a downward trend. We are still not meeting our constitutional standards. Although we have seen improvements in the 4-hour standard, that is still in a state of flux because of the pressures that we're under, and trying to stabilise that. I think Debbie has discussed one of the things that holds up a positive position on the 4-hour standard is the MIUs, but that also we must be really clear that we don't have minor injuries now on site at RCHT, so they are dealing exclusively with majors, which has an impact on them and the way in which we measure. So I think that's important to note that. We remain, as we say, under pressure. We had a better month in December, which isn't reflected in this, but I do think it's worth noting. We do see changes in people's behaviours, particularly during industrial action. So that had seen December being quite a good month. We are now into January, which has been difficult, and that's reflective in some of the metrics that we've seen for November. We continue to work with, as a system, with ESIST and with our NHS England colleagues around our Tier 1 actions, and where we see some improvement, we're also not seeing an improvement that's fast enough and sustained, and we know that we still have some issues in smoothing out some of our services over a 7-day period, and again working to try and smooth out that performance. Our elective care performance chair, again, working closely with RCHT because we have a target of 0.78 weeks by the end of March. That at the moment is at risk. However, we know that a lot of those weights are in one specialty, which is trauma and orthopaedics, and we've been working with the trust about how we offer choice to patients, which they are now picking up. And since, I think it's September, Steve, if I'm right, around about August, September, we've seen 449 people have chosen to have their surgery somewhere else, which starts to relieve the pressure that's within RCHT, particularly on that trauma and orthopaedics, the orthopaedic backlog in particular. We are seeing improvements in diagnostics, which is great news, because when you see improvements in diagnostics, you start to see improvements across all of your RTT, your referral to treatment times. And we are seeing, although we are monitoring the cancer standards very closely, we have seen some improvements. That's been aided by what is in the IPR as the faster diagnostic standard, which is at 78%, and we're expecting to maintain that through to end of year. But as I say, working with the trust around the 62-day target as well for cancer. We have had significant pressure on mental health services, something that we flag each day at our system coordination centre meeting. We have seen some reduction in out of area placements, which is the trend that we want to continue. We have had some issues flagged to us about some of our out of area providers. So my quality team have gone and visited 3 of those providers. I think the last visit was yesterday, if I'm correct, to assure ourselves around quality and how we're advocating for those people that are not within our county. I think the critical incident hit mental health just as hard as it hit all of our other services, and we continue to see delays for people trying to exit our mental health services, something again that I know CFT are working really hard to mitigate where possible. And I think some of the services that we're seeing through the community hubs are really helpful, but it's understanding how we can do more in that phase to try and prevent some of those admissions. I don't think at this point I have anything else. We are obviously monitoring quality very closely. These are discussions that are not going on locally, but also regionally and nationally, because safety across the board, when we've all got backlogs and ambulance holds, we know that overcrowding in ED creates potential harm to patients. And we will be talking about the work that we're doing currently with our coroner, particularly around our Regulation 28, learning from deaths, and how our coroner is going to join our mortality and morbidity system meeting. And I think it's just worth reminding everybody that we were one of the first ICBs to bring morbidity into mortality, so that we are tracking harm, not just our avoidable deaths. Really important point. So quality is something that's very much on our radar. And again, we go through our harm metrics as part of that meeting that we do in the SCC, the System Coordination Centre. I'll take a breath because lots of this is in my head and there's a certain amount of distance. So I'm happy to take questions.
So just before I bring Sanj in, I think one thing I want to say again is that I think noting this is information up till November, I'm quite keen to get on to the winter paper, which is more live, if that's all right, colleagues. So if you want to ask a question, fine, Sanj, go for it. But I think we will come back to some of this more live.
It's just a simple clarification, because in the sort of exec summary, we talk about 97% bed occupancy. The table with lots of red on page 2 of the main report has 95.5, which is much closer to the 92 constitutional standard. So which one is...
So we have been running at 97.
Okay.
And in fact, we are still fully escalated, in fact, so that would suggest we're even higher than that. So we have not de-escalated from those escalation beds, either in CFT or RCHT.
Steve?
Yeah, sorry, the reality is that Royal Cornwall Hospitals is operating at over 99.5% bed occupancy. We see that reported, Susan, in the weekly NHS England Southwest regional reports, and for the last 2 months, if not longer, RCHT has had either the highest or the second highest bed occupancy in the region. In most instances, it's the highest, but certainly it's at the 99.5% bed occupancy level. And actually, the way in which the reporting is undertaken, that potentially understates the position, because that includes in the denominator the extraordinary surge bed capacities which are in use where, for example, additional beds are in place within a ward area. So just for clarity for the board, we've got the biggest gap to the 92%.
That's why I want to get onto the winter plan,
region.
because this is out of date. I mean, it is what it. We can't get any faster. This information for an IPR, so it is what it is. But we have more recent data which we need to come on to, Sanj. All right. Debbie?
I'll keep my comments on anything UEC for the winter plan update, Chair. But I just wanted to also point out that with mental health, the definition of no criteria to reside is really quite constrained. And actually, we need to become much clearer about those people who are delayed, waiting an onward placement. But because that onward placement has not yet been identified, they're not a delay. So I think as we start looking at how we manage our mental health beds better together as a system, and we drive out some of those delays, we need to get into looking at that. The other thing is that I would ask for next year's IPR that perhaps we could report against future trajectories as well, because it's really stark if you look at the NHS talking therapies that activity plummeted over Christmas and New Year. But actually, that's not surprising. That's an artifact of people actually not wanting to access therapy over those periods. But it does mean if you're looking at managing the quantum of activity across a year, you've got to actually catch that up in prior or preceding months.
Thank you. Rachel?
Thank you. This shouldn't come up. Well, I'm not imagining it will come up in the WINS plan, so I wanted to highlight it really because I picked up that there were a couple of mentions of both in the quality and safety and in the primary care performance around poorly managed hypertension and this leading to perhaps higher risk of stroke. And that difficulty in sort of ensuring good management of cardiovascular risk. So it's come up a couple of times in the report. So I think it was just drawing the board's attention to clearly there's something that there is avoidable. And I think, you know, again, bringing up the opportunity to do some prevention and better management of risk, and then the opportunities for, you know, upstream prevention as well on that. So these things are evidence-based, and I think we need to pay a bit more attention to that in some places. And I know it's a clinical priority, so I expect that to be coming back here. But I just wanted that to be noted because the stroke deep dive that you referred to did highlight that, as well as the performance under primary care.
Mention it, Rachel. So so our clinical strategy that we presented at board talks about those particular areas. So cardiovascular, respiratory, and diabetes. The clinical reference groups are being set up. Some are already up and running. Because you're absolutely right. It has to be end to end. It has to be what we're doing around prevention. So I know Chris is keen to bring something back to board to go through the progress today around clinical reference groups, and then the wider group, which is the clinical prioritisation and advisory group.
Can that come back next month?
Yeah, I don't see why not.
I think it's
If
important.
the agenda allows.
Yeah, no, I get that. There's some part of me, the reason why I say it is given next month's going to be focused on budgets, you can't help but feel the clinical need to get budget ownership.
I think we just need to be clear that what we would bring back is, again, it's a moment in time on the journey of setting up of those clinical reference groups and what they're
Well,
doing.
let's see if time allows them. Okay, fine. Okay, thank you. So can I bring in Patrick? Anything on workforce that you want to feature?
Not particularly to highlight, Chair. I've got nothing to add to comments made at previous meetings around the work in progress on workforce data. I would just highlight in the report, pages 28, 29 shows agency usage, which in both trusts is showing a reduction. Colleagues are working extremely hard on the controls that regulate agency usage. There's a lot of progress still to be made, but because that was a soft measure, I just wanted to draw board's attention to that, which is in the report.
Steve?
Yeah, that's really helpful to see that progress, Patrick. Just was supposed to make the connection to the comments that Debbie was just making about the number of no criteria to reside patients which are occupying RCHT and CFT, and from a Devon perspective in UHP, because they're so far higher than our plan within the system, that does generate, Patrick, a need for some of this additional staffing capacity to be able to safely manage those patients. So there is a direct correlation between the operational pressures, particularly with regards to the system having significantly more no criteria to reside patients occupying hospital beds than the plan. And perhaps, Patrick, in future, if there's some way of making some explicit connection or reference to that so we can understand the scale of that might help us to manage this going forward.
Patrick's happy with that. So let's move on to, where are we now? It's the 8th of February. How's 23-24 going?
So I should summarise from the paper, which people would have seen. We're still on track, recognising the operational issues Steve just highlighted, to deliver a position which is described, I think, in the current report as a 2.7 million forecast shortfall. And all the trajectories for each of the three organisations is on track to deliver that. The only area of clarity that we know we're waiting for nationally still remains the funding in relation to industrial action. So we are now expecting for there to be funding to come through, but we're still awaiting for clarity on the summer money that relates to. And with CFO colleagues, we'll be testing that against the costs that we've reflected in the forecast outturn position so far. So at the moment, still on track, but recognising we've still got some operational pressures to manage through. So I've got nothing else to add at this stage.
Just so I'm really clear, what does that mean for break even?
So on the basis that an allocation comes through, the expectation is that we should be then planning to break even, and that has obviously all the implications we talked about before. So assurance that you get previous year's debt written off, and incentive for capital. So at the moment, the expectation is it will balance, but it does need to be tested and validated as soon as we know the summer money coming in, and that we don't know at the moment.
Can I just reach out to Steve and Debbie and just get your insights on how you're feeling between now and year end?
Incredibly hard across the system, in the ICB, in CFT and RCHT, and across the entire system to enable the environment that Simon's just described. My understanding is if we were to be funded in full for the costs, the direct cost and the lost revenue of industrial action, that would allow the system to forecast a break-even position. As Simon has said, we don't yet have the clarity. I think there is some indication that potentially direct costs might be funded, but lost revenue might not be funded. And if that was the case, that would leave a gap, Simon, in the order of 700,000 or 800,000 potentially. So it's very close to a balanced position. But we don't yet have the clarity on how industrial action will be tracked. It's also possible that industrial action wouldn't be funded. But aside from that, an otherwise balanced position might allow systems to write off historic debt. So I think, Simon, if I understood it, there's still a little bit of uncertainty. But the headline I've drawn from the report is if we exclude the December and January's industrial action, excluding that, we're on track for a system balanced position.
That's my understanding.
Yes, correct.
Yeah,
agree.
I think we should note that, if that's all right, in the minutes. Whoever's taking the minutes today, Molly, thank you. It was actually, can I just go to Debbie first and then Martin?
Yes, you asked for confirmation from both Steve and I, so I'll put my CEO hat on, and I'm happy to confirm that CFT's financial recovery plan remains on track, and any risks to that have been mitigated internally. As we rehearsed at the last ICB, however, the system balance requires the 9.4 million deficit in CFT to effectively be rebalanced from other sources, and the impact of industrial action is now reflected in us showing a deficit, although that is currently under some discussion.
Probably
So
Martin, did you
CFT's
want to
position
respond to that?
hasn't deteriorated,
Okay.
but the presentation of that has.
The observation we have.
No, that's correct. So, and I think in an ideal position, we'd be able to balance the position off for the system, and CFT's position would follow that as well.
Thank you. Martin?
Thanks, John. Yeah, I mean, I think, summary, we're doing really well this year, which is great considering the amount of risk we had at this time last year when we were trying to set the budget, actually. My slight worry is the underlying position, and although we're delivering the efficiencies, we're not delivering them recurrently, if you read the report, if I read it correctly. And, I suppose, trying to add it up, we had a 26 million target, and it looks like in the current report, we're only due to deliver 6 million of that recurrently, which is going to leave us, if I understand it, with quite a significant hole going into next year. But part of the thing that drew my attention to it is last month, we were projecting £9 million recurrent delivery, and this month it's dropped to 6. So we sort of lost £3 million in a month, which in one sense doesn't sound much in the scheme of things, but when we're looking at budgets for place, for other things, 3 million is the sort of quantum that actually would make quite a bit of difference. So I guess how have we lost 3 million a month? And I suppose why is the delivery so bad, really? It seems to be negligible.
What I would say is and it's reflecting in some of the challenges of putting the 24/5 paper together. RCHT has reviewed its position, which would change what's included in that report in the last week. So that would improve the recurring impact element of delivery in 23/4, helping us in 24/5. So that's a bit of a plus from what you're seeing. So you'll see a slightly different position when it's reported next month, given the work that's been undertaken in RCHT. I think there's a whole range of issues that we need to focus on to resolve 24/5 with CFO colleagues in going through the detail and optimising the benefits from this year into next year, and that's still work to be done.
So further analysis is revealing an improvement, we think. That's good.
And that's the value of recognising papers go out in a week in advance. That's the value of actually having a immediate update that there's an improvement on that situation. Okay. Anything else on the IPR before I move on then? No? Okay, so let's have a quick count around each of the committee chairs and partner member updates. So just looking around, I'll start on this side if I may. So Tom? Carol? Sanj? Martin?
Quickly, if I may, only because I think you raised it last time that we were due to look at the internal audit plan. We've only just had the meeting this week 2 days ago, but I suppose just to give some assurance to you, John, because you raised it, I think that as part of the plan next year, we're looking at, the revised governance arrangements within the ICB, the new wiring diagram of meetings under the new structure, how information flows, which meetings are minuted, and, just aiming to get some independent assurance that governance is now working and appropriate. Just for information, we also looked at the external audit plan. We'll be looking at our accounts and other things for the year. And it just reminded us, that one of their issues last year, they made a significant recommendation around our arrangements relating to financial stability with 10 recommendations. So we will be with them revisiting those to assess how well we've implemented those recommendations from last year.
Okay. Nick?
So I stood in for Neil to do an ICA meeting where we had one paper to consider. The committee agreed with direction of travel, but asked for some more assurance around that paper that was presented by Emma. But lots of feeling around direction of travel was the right thing to do, but more assurance required before we could bring and consider it to board, John. Thank you.
Lovely. Okay, so let's go around from... I know Ali's off at the moment, so Rachel, can you just start from Ali's seat? Is there anything that you want to report from?
I mean, I think the data in the report is as when it was written, so I'm happy to sort of take back any questions on that. Then there was a bit more information about physical activity and the work going on to promote people getting active and preventing falls included in that report as well.
Good. Debbie, from the mental health perspective?
Nothing to add, Chair.
Yeah, thank you. Steve, from NHS providers?
Nothing to add, but if I could just reinforce one of the points that's in the summary, which is the really significant key risk that UHP, RCHT and CFT continue to face regarding the number of no criteria to reside patients within their beds, and particularly the fact that that is so far above the system plan that is having a direct consequence on our H2 requirements around ambulance handover performance and in other areas as well. I know that is said in the report, but just to emphasise the significance of that and the level of impact that that's having.
Okay, thank you. And Andy isn't here today, so there's that. Just looking at other colleagues who have the opportunity. So, Emma, anything you want to raise from your seat?
I mean, just to pick up on the point from Nick's committee around our continued statements around channel shifting, and just to remind board that we do need to come back to that over the course of the next few months. I know financial budgets are tight for everybody, but we also know the trajectory for our people and communities and for our staff and for the system in terms of its finances. So I would hope that we will continue to come back to the prevention agenda as we start to think about both next year and future years, and pick that up more fully.
Thank you.
Perhaps we'll have a discussion later.
So I don't think I've missed anybody. If I do, I'll just pause for a second. Anybody who would like to add from their committee perspective or partner perspective? No? I think I've called everyone.
Sorry,
Okay.
Chair.
Yep.
I just wanted to flag that in the Quality and Pathways of Care report, there's some assurance on the action that was delegated by the board in November around equality impact assessments. Just wanted to note that for the minutes that action has been discharged.
Thank you for that. Okay, so let's move on. So that's actually given us quite a bit of time back, which I'm very grateful for what is a critically important item, which is the winter plan. So, recognising that all reports are written at a moment in time, this report came out a week ago. Has to, because it's a public document for part one. So that's come out. But like a lot of these things, as soon as it's written, it's out of date. So I would like to invite Susan to give us a further update as to your perspective since that report was written on how things are going.
Thank you, Chair. And I think it's fair to say that we agreed with the winter plan that we would invest into 10 initiatives tied into some of the work that NHS England at national level had been doing around 10 high impact changes. It aligns with the outcomes that we're expected to meet in H2 and overlaps as well with Tier 1. So what we tried to do was create a winter plan that wasn't yet another plan on top of 2 other plans. It was to work seamlessly together. So what we've been doing, we're now at the end of January, and we have been reviewing the winter plan to date. And what I'd like to do coming through SEG, which would be next week, would be to bring the latest position of a RAG-rated plan against the 10 initiatives. I just wanted to outline, and as you rightly said, the paper was a point in time where some of the areas of the winter plan were working. I think we've discussed that January has been a particularly difficult month, and some of those initiatives within the winter plan have not realised the benefits that we would like them to realise. So if you could just bear with me, if we could just go through the initiatives, Chair, and our next steps that we would like to take as a result of the work that's been done. So firstly, we had an allocation of around 3 million. To date, the forecast spend against that is 1.729 million. So we have got quite a significant underspend. However, we would like to talk to our clinical colleagues about how we can use some of that money differently, but more importantly, quickly, because what we can't afford to do is have schemes that won't hit an impact for all of the reasons that we've discussed through the IPR and people trying to leave hospital. So the key schemes that we are delivering, and I won't go into detail because you'll have the detail within the paper. So we have the Right Care car is delivering, and during our critical incident, the Right Care car went down to support some of our GP practices who had declared Opal 4 themselves. So very flexible service and agile, which are incredibly important, particularly when you're in critical incidents and in fact system Opal 4. So the early indications is the Right Care car has been the right thing to do. The Care Coordination Centre, which was a national mandate, we're continuing to review that and make improvements as we go along. And that link between our ambulance service SWAST, it's a shame Neil's not here to talk this through, and our IUX, which is our the words have gone, integrated urgent care service, have worked really well together, and some of that has seen some real benefits to our stack that sits within the ambulance service. We'd already been doing quite a lot of work in Cornwall ahead of the curve on our category 3s and 4s, and we were looking at how we could pull some more people out of category 2, or at least reroute them away from the acute trust to our UTCs. We've invested lots of money and resource into urgent treatment centres, and CFT have wrapped their community assessment and treatment beds around these services, again, to offer an alternative. So the Care Coordination Centre is that. It's a coordination to try and move some of those people away from the front door of ED. Our X-ray car has started within the last 7 days. It's very early indications. I wouldn't want to draw any conclusions at this point, but we are getting favourable feedback on the X-ray car. It tends to work side by side with the Falls car, as you would expect. We are looking to see whether or not we can review the clinical criteria around the X-ray car to look at other conditions that we see around falls. and also things like chest infections, those sorts of things. But that's going to have to go through the clinical review group to ensure that we've got the appropriate safety netting around that and risk assessments that are being done. So early days for the X-ray car. CHS, that's a company that's called Care Home Selection, and that works with, and again, it's early in the stages, it works with our providers to place people more effectively and quickly out of the hospital. And we're seeing, I don't think we can, again, draw conclusions because it's early days, but certainly the work that CHS have done in the past has been successful, and we will continue to monitor that, in that it's one of our goals that we ensure people get to the right place first time, and also the amount of people that we place into bedded care, we know that we're above some of the national averages, so that's something that we're really keen to reduce, but that has a knock-on effect to our P1 capacity, and that's taking people home with some care to their own homes, not into an institutional bed. So CHS work is incredibly important. And the care home support team, extended hours, again, very important. And this starts to address some of those issues that we've talked about around not only 7-day working, but it's also working out of hours. And we see that people they've not been able to reach a healthcare provider during working hours, often will opt to call an ambulance or self-present to our A&E department. The areas that we've not seen sufficient impact, I think, is some of the investment that we wanted to put into and very keen to put into our packages of care, both complex reablement packages. P2, these are people that need some form of bedded care, usually within our community services. And P3, particularly around dementia, we've not landed for a number of reasons. I think the feedback that we've had is that some people who are in earlier stages of dementia, the treatment plans are slightly easier in terms of placement. It's those people that are sort of really in the further stages of dementia, where care is much more complex and much more difficult. And we've taken the view as a system, and we want to explore this further, having thought that we would look to procure one space for these patients. We're not sure in terms of patient experience and family experience that's the right thing to do. And we certainly don't have any providers at the moment who feel that they have the resource and the expertise to take on around 14 beds is where we wanted to look. So the model that we're looking at the moment is how we disperse that across our system, giving our people the best possible experience. What we have been doing, which hasn't been, I don't think, as noticeable, is as part of BAU, working with our council colleagues, is we spot purchase, and we haven't drawn down any of the winter funds to do that spot purchase. However, the schemes that we have and the ideas that we are now looking at will draw down on the winter funds to around about 400,000. We are looking again, and again, it's not ideal. Some of the more complex P1 packages of care is, could we put those into a bedded facility, but safety net them in some way? And we've talked about this during our critical incident. And again, this is where the learning is so important. Our virtual wards, again, being very agile and flexible about whether we wrap a virtual safety net around people that are placed in whether it's care homes or residential homes who have slightly more challenging P1 needs is another area that we will look to do during winter. But it's certainly not a direction of travel that we want to take in the longer term, because we know that that's just creating more dependency on beds, on bedded care, which we know is not a good experience. The other area that I would also like to draw attention to is the primary care hubs. So we were really clear at the outset of winter, we would try and take some further pressure off our providers by having primary care hubs in some of our more deprived areas and where we see our greatest demand. We are not seeing the footfall that we thought we would through those primary care hubs. And as such, they've not drawn down on the amount of money we expected them to. So the conversations that we've had, and this is why the winter plan has to be dynamic and iterative, the conversations that we've had with primary care during this week is how we provide more locum capacity into the system, again, so that we can offer people more choice. And we certainly did that during critical incident. It worked really well. we've done a very quick appraisal of that, and it's something we think that we can offer. That would draw down an additional 400,000. So the schemes that we would like to take, and just to remind everybody, we said that we would be clinically led for the winter plan. We would like to take some of those schemes through the next Tuesday's clinical executive leadership meeting, which is an hour. And then if they are supportive of the schemes, we would take that through SEG on Friday with a much more concise paper to go with it, which gives the RAG rating on the schemes. I think the other thing that I just would like to throw in is there is another organisation called CLEAR. They've worked with a variety of trusts. The one thing that we've not landed in Cornwall, and I think would be great to land, is the discharge to assess model. CLEAR offers that, and we know that we've had an offer from HEE of a third to cover the costs, another third coming from potentially NHS England, and us offering up a third. So that would take the total underspend if we went with all of those schemes, and I'm highlighting it, I'm not asking for decision, obviously, from board, would take us to an underspend of 250,000 on the winter plan. But we do need to talk about these plans in more detail in the clinical forum to see if they are actually going to land the benefits that we need to land to allow both RCHT and CFT to move some of those people that are within the hospital that are currently delayed. Can I take a breath there?
Yes, please. Thank you. So I think it's important that we get a rounded view, a latest view. Three areas I'd like us to maybe just touch on as we go through here, and getting the perspective as an update, is how we're doing on elective through the winter plan, how we're doing on discharge, and just going over once again the planning for, once we establish if there is an underspend to 3 million, how we execute a redeployment of that relatively quickly. So can I just, in order to make sure we have a wide perspective on top of this, can I invite anybody who would like to add any thoughts to this paper? Feel free to think about elective, discharge, or how we go about the £3 million. I don't mind. If not, happy to press on. Debbie.
Come in on the discharge
Yes.
piece, given your invitation, John. So I am delighted to say, because colleagues will have heard me raise concern here, that home first delays were running at between 15 and 20, and that was causing a considerable block. And we often talk about beds, but we don't talk about blocks in community capacity awaiting onward care. So I'm pleased to say that as of today, recognising, as Susan says, these things change on a day-by-day basis, but as of today, we've got 7 delays across the entire county. So that's a significant improvement. However, of those, 3 of them have been waiting more than 120 days. And 2 of those 3 are actually up at 140. So that's a lot of lost NHS capacity going into people's homes 3 times a day. And you can imagine our productivity challenge with the coastal and rurality impact that has. So they might be small numbers, but the impact of some of those delays is quite significant. And the target is 28 days. So you can imagine how many more patients we could have put through that pathway. However, our no criteria to reside, we almost are now operating out of what I sort of call high turnover beds, and now we've got slow turnover beds. So our no criteria to reside in CFT is up to 102 waiters as of yesterday, but balanced against that, there are 58 people waiting in RCHT and Derriford for a community hospital bed. So you can imagine the pressure that our teams face when there's that quantum. And this is the highest number of community hospital bed waiters that we've seen. So the impact of delayed discharges in a community provider then impacts on both RCHT and CFT directly. And Professor Tim Briggs recently visited UHP and set a threshold for UHP of no more than 7% of their beds to be with delayed discharges. Now, no such threshold ever gets set for a community provider. But if you were to set that threshold for us, we would immediately free up at least 60 of those 102 beds. We only have a bed stock of 264. And if I come back away from the statistics and talk about the impact on individuals, these are individuals that are in community hospitals who could be in a better place of care, either in their own homes or in a care home. But also we're restricting their opportunities, but also because of the system pressures, we are now in boarding as well as escalation, then boarding, now boarding plus. It means that some of our day rooms and some of our reablement gym facilities are being used to increase the bed capacity in community hospitals. That then has another knock-on effect. So we're doing our best. You can see the activities that are there on the ward, but I would nevertheless like to raise those as issues. The final bit, John, though, is, and you've been to see it yourself, the Frailty SDEC on the Bodmin site is up and running. It saw patients on its first day, which is great. It's part of the winter funding. It has been open 5 days a week, 11 till 5. We're now into the 11 till 7, and after half term it will be 7 days a week. It's really being appreciated by people who use that service, so that's our most important litmus test. The GPs and the nursing staff that are running it really can see this is a significant opportunity to improve care for people closer to home and away from the emergency department, and GPs and SWAST are giving us favourable feedback. But this is one of those areas where we've had to backfill experienced staff with agency. So you'll recall the conversation earlier about agency. This is one of those unintended pressures that then comes on with very short-term money. Thank you, John.
Can I bring in Rachel?
Yeah, thank you, Chair. Can you just check you can hear me okay?
Yes, thank you.
Great, thank you. Firstly, I'd like to acknowledge that the system is showing a level of maturity around recognising that this is dynamic and reviewing it and responding to what are kind of emerging issues. So that I think that's really positive, and it's good to hear the initial analysis of things that are working well and things that need either to be refreshed or reviewed. I suppose my reflection from a regional perspective is that we are seeing now an emerging issue around delayed discharge, which I know Steve and Debbie have both iterated, and I think that's probably got to be a focus collectively together over the next few weeks. I think the system can choose to set its own targets. I don't think one does what does to another. So I suppose to your point, Chair, about the kind of collective leadership being in the room to solve what are really difficult issues, and obviously in a very dynamic system, I think a focus around discharge so that that loss of capacity, as you say, by this increasing no criteria to reside number, which will impact on the workings of organisations, I think is an important focus. It's good to hear that there are ideas coming ahead of that. I think the ideas need to think about the P2 and the P3, particularly people who require kind of ongoing care. So that for me is where we'd be looking for the system to focus. Thanks.
Yeah, John. I feel somewhat constrained in my ability to comment or challenge the content of the paper. I have shared concerns with you and with Susan prior to the meeting. I don't believe the paper reflects the position of the winter plan at the time in which the paper was issued. So if I know we've touched on some of these, I don't at all disagree with the dynamic nature of this, but when the paper was issued, core parts of the winter plan were known not to be delivering. So just to provide some examples, the 14 additional dementia beds planned for January, I understand are not implemented and won't be implemented to April. The 10 additional P3 beds haven't been implemented, and I understand there isn't a plan for them to be implemented. The additional primary care capacity, which was planned to deliver 12,500 primary care appointments, I understand is now projected to deliver 2,732, so about 20% of that. The reason for mentioning those in the context of the no criteria to reside position is there are three key elements of the winter plan: the 14 dementia beds, the 10 P3 beds, and the CHS work, which together were designed, and this is explicit in the winter plan, to reduce by 50 the number of no criteria to reside patients in RCHT and in CFT. If we'd achieved that, we'd have 50 fewer patients than we have now in those two organisations, and in 80% of instances we wouldn't be holding ambulances. The reason for raising those matters, and John, as you're aware, I have shared them with you and Susan in advance, is none of that's reflected in the plan, in the report rather. The report makes reference positively to not escalating to critical incident in the period around Christmas and New Year, and of course that's correct. The report doesn't make reference to the fact that we did subsequently escalate to critical incident. So we do seem in this report to be picking and choosing individual snapshots. And I have to say, with consideration, not representing in a published board paper the matters of fact about the position. And apologies for raising that. I do choose my language carefully.
Ollie, can you just help me here in terms of the paper and the journey it had to get here? Because the other thing I want to just pick up on is something I said at the start, which is it's quite used to actually having papers done at a point in time. And I did give everybody the opportunity to then to actually give an update since the paper has come out. So I was hoping to actually get that out on the table. But Molly, just so everyone is cited on this and the paper, can you just give us your perspective on this, please?
Thank you, Chair. So the paper was published on the 1st of February, which was also the same day that it was received by the Finance, Performance and Commissioning Committee. At the meeting of the Finance and Performance Commissioning Committee, there were some actions raised for consideration for updates. But as you said at the beginning, Chair, those actions were also in recognition of the fact that the paper had to be published within the 5 working day period. And so for that reason, Susan opted to provide a verbal update on elements of the paper that were not included at the time the report was published.
Is there anything you want to add?
I take Steve's comments. I think that some of the issues that we've been experiencing is there's been underlying issues that we weren't, although we knew things within the winter plan were not working as well. It was getting underneath some of the detail. I'm happy to take responsibility for holding that and trying to bring a fuller update as we go through. We agreed that we wouldn't put anything into the paper around the critical incident because we are still waiting for providers to feed back to us on their learning, their experiences, so that we can do a complete tabletop review, which is the process that we have to follow as part of governance for critical incident. And what I wanted to propose was to bring back the paper that has a full RAG rating of all of the schemes. And thank you, Debbie, for reminding me on the frailty SDEC, because the parts of the winter plan that have succeeded, of course, the uptake of virtual wards has been incredibly important. And the feedback that we got from the clinical meeting last Tuesday from providers, senior clinicians, was they have seen an improvement in some areas, particularly around frailty attendances. And I think, notwithstanding the comments that Steve has made, there is still more to do. So I took the decision to publish the paper. I take the constructive criticism in the spirit in which it's meant, will ensure for the next paper that's brought back through our agreed governance that we have a very clear description of the schemes that are working, the schemes that we know are not going to fulfil what they need to for our winter for whatever reason, and be as open and transparent as I possibly can with the knowledge that I have around why they're not working. I think in terms of the 10 beds, Steve, the idea working with adult social care colleagues of placing people, those P1 people in particular into 10 beds, I think is what we need to crack on and do. But it does bother me that we are putting people into beds when we don't have a P1 market at this point in time that's enough to service the needs of our people that are sitting within our CHT. And as Debbie rightly said, also on some of the other caseloads that we don't necessarily have as much in-depth analysis of, like Home First, for example. So I'm happy to bring back another paper and accept Steve's observations.
Nick?
Yeah, so thank you, Chair. I think in my sort of new role within the committee, I think what I'm seeing here is actually a system that's owning its plan, a system that's challenging its plan, and I think doing that in the right way with the right levels of checks and balances in that. I think information that comes in a live and changing and dynamic system, as Rachel has described, is one where the information is required, and I think those verbal updates and the challenge which people have brought is what good leadership and governance is about. And I think those learns are taken forward, and the recognition in a dynamic system that we all own that plan, and some bits are working, some bits need tweaking and finessing, but that ownership of the plan and it being clinically led, I think, is what I'm drawing from that throughout that challenge, Chair. Thank you.
And if I can just add some observations, I think that it is incumbent on us all, and particularly the authors of the papers, to ensure there is a rounded perspective at the time in which papers are issued. So sometimes we get that right. Sometimes we make a decision to actually update on the day, and I respect that. I think the thing I'd like to try and move us on to is, I forget who I was speaking to. I've had loads of conversations in the last couple of days. I think we quickly jump into the bits that are going wrong, and we'll need to focus on those. But there are some elements that I think we should not ignore that we've done rather well as well. Some of the celebration of this, the avoidance of getting people to going into a UEC environment, a huge amount of effort that's going on there. We can do more, but we are doing some good stuff as part of the winter plan. But as raised by Steve, there are clearly some areas that we just need to unpack in a transparent, collegiate way, without looking back. It hasn't worked. Therefore, what will we do now? So I guess what I'd like to move on to is, given the fact there have been some success stories in the winter plan, our winter plan, that we all signed off, given the fact there are bits that we always knew we didn't know they weren't going to work, but we knew it would be iterative. Therefore, now that we've got some sight on the bits that aren't going to work, I just want to get some clarity now, if I may. How do we now get the right teams tomorrow, Monday, whatever it takes, to sit in a room and say, how do we move from what was the original plan and how do we iterate it to a new one? And if there is an agreement to do with an underspend, how it's redeployed? Because there's something that I'm cited on in terms of the number of the GP options that we gave has not lived up to what our expectations were. Now, somebody somewhere quickly needs to decide whether we're going to try and ramp that back up again, or decide it isn't going to happen and do something different. So I'm just trying to get clear, who is it who's going to raise that? So I'll come to this in a second, but Neil, you wanted to raise something? Is it on that line of question?
Yeah, it is, John. It's really just to say that, particularly with regard to that GP plan, I think it's important that whilst Nick used the words tweaking and changing, and you're looking at where we prioritise the next bits of the winter plan, it's really important to remember that this was something that was part of GP transformation as a whole, and whilst it needs looking at and needs a clinical appraisal and decisions need to be made in the here and now, I would not like to see such a plan completely abandoned across the system in the light of this.
Thank you. So actually, just before I bring you in, can I invite Molly just to give some feedback on my thoughts?
Thank you, Chair. From a corporate governance perspective, I think recognising the timing issues that we're faced with the paper, I'll just recommend to the board that we put as an action for us to bring an update with the next iteration of the winter plan paper, specifically addressing the points raised by Steve. So for completeness, we've got that information.
Steve, you had your hand up. Would you like to respond to Molly first, if that's acceptable to you, and then make your point?
Yeah, I'm not sure I see them as timing issues, John. I did raise concerns a month ago on a similar matter in terms of accuracy and content. But what I wanted to comment on was Neil's comment. And Neil, I welcome your challenge. I do have some concerns. When we first considered the winter plan, the intention that was put forward was for 60,000 additional primary care appointments, 15,000 a month. That was reduced because of the financial envelope available. But the reality is we're going from 60,000 as the initial intention to 2,700. That does fill me with concern about whether there is the capability and capacity for some of the community interventions which are currently part of our plan. We did make a conscious decision to invest in community. We could have made other investment decisions. We chose not to open additional inpatient capacity at RCHT. We chose to invest in community capacity, and I support that. But given the challenges that we're now having, and if I take that example of how on earth do we go from an initial plan for 60,000 additional primary care appointments to the reality being 2,700? I think the risk we're facing from a community capacity is very significant.
So let me pick up on some of those points, because some of that might be new news to some of the board colleagues. So you're right, you did raise last month. I did ask the executive group to look at that, and I came back to you and actually said the substance was in the view of the author faithful to what the position was that they saw it as. We can always disagree on papers, because the implication in some ways is that we can't issue a paper until everybody in the board agrees with it, which is clearly not going to be the case. So I appreciate there may have a different interpretation on the January paper. I think I've come back to you on that. I think on this particular one, the reason why I wanted Molly specifically to share with the board the journey of this paper is that, and I hope I did stress at the start, this paper was written at a moment in time. It was issued in time for the public board meeting, and the idea was then to ensure that there was a contemporaneous update today, which I think you've given. I think we're unpacking the question as to some of the issues as to the number of GPs, the dementia beds, the P2, P3s and that kind of thing. We have those, and that's why I wanted Molly to really raise the fact that we will then come back and specifically answer those particular questions that you've got, such that as you've raised them, particularly as you're a statutory board member of the board, we need to answer that to your satisfaction, and we need to make sure that we give a cogent and suitable answer to that. And if we haven't done that, then we need to do so, Steve. So does that reassure you that we will do something to address your questions for the next board meeting?
I appreciate the next steps.
Yeah, well, thank you. So in terms of being supportive of going to the next bit, can I just therefore just get real clarity, Susan? As I was trying to say, that there's certain elements across this, whether it be the ICB, the providers, general practice, it's a wide system plan. How do we make sure that quickly we know who's going to be sitting in a room saying those bits are working, continue, these bits are not going to ramp up to the expectations that we expected, therefore, excuse me, I'm going to give it up for Lent, move on, and redeploy that. Who and where is going to make that decision quickly and decisively and collectively across the system?
So the work that's been going on this week in RAG rating and reviewing all of the 10 schemes, I asked Leighton Day, who's just joined us recently as our interim Director of Delivery. He's been working with colleagues either in groups or individually, speaking to colleagues also in adult social care as well as across the board. I have to remind the board that we agreed the winter plan would be led clinically. So the area where the group that we would take this to initially, where we've RAG rated and have potentially come up with other solutions and ideas, would be that clinical meeting, which meets next Tuesday. So we will have a fully worked up RAG rated plan, which I'm happy to add as an addendum to the minutes if that would be helpful. We were still waiting for some information to come back as of last night, which is why you didn't get it today.
Okay.
And then what we would do is take it for further where the decisions have to be made, and either supported or not, would be through SEG, our System Executive Group, which would be a week tomorrow.
Okay.
And that's the timetable that I'm working to at this moment.
I'll come back to him. But Debbie, was your question going to be on this point? Because Mary wants to come in, I think, on this point.
No, I would like to talk about next plans. So if I could come in on that when
Okay, cool. So
convenient.
let me see if I can get to that in a second. But Mary first.
I think probably points have already been made. I suppose my concern, and I very much appreciate what's already being proposed, my concern is about pace. Because whichever decision we make, how fast are we going to be able to stand them up? And I might be wrong, but it seems to me it could be quite difficult to stand up new things. And I just wonder if the people who'll be looking at this might consider augmenting existing, because it might be easier to stand up than something new. But my concern is pace.
Okay, so before I come to Rachel, this is one of the themes I wanted to pick up on here, because we can have a process, but is the process going at pace with the right people in it? So it's got to be clinically led. But can I just be really clear, who by what timeline will be saying we're going to upgrade that, invest in it and commit to it, or we're going to give it up for Lent and repurpose it and clearly understand that? Is that going to be within a week? We can't wait till the next board meeting. So
week tomorrow.
a week tomorrow, that the conclusion.
We'd be bringing the the paper to SEG.
And therefore the three chief executives and their teams will be...
Can I be really clear as well? Yeah. When we are in critical incident and when we're in Opal 4, we make these decisions on a daily basis. We don't wait for committees. We take it on the balance of risk. We introduce dynamic risk assessment into Cornwall and the Isles of Scilly. And we do that on a daily basis. So I don't want anybody to leave the meeting thinking that we're leaving everything in abeyance. We are finding out more and more about where the winter plan is working, where it's not. That's not waiting for a board or a committee. It's being discussed every morning. It starts at 9 o'clock on the system coordination, where we have NHS England there helpfully to challenge us on our direction of travel. So whilst we have a governance that we have to commit to for decisions, and this is a large sum of money that we have to show we are spending and spending appropriately, the decisions that govern our patient safety and the experience of the people we serve, we do on a daily basis as part of business as usual.
So just again, trying to get to the thread of, I think where Mary's trying to go on here is that accepting that if there is an underspend of any degree, are you saying to me at SEG in 10 days time or a week's time, that will be the moment where the moment of decision will be taken to either press on with the plan as is or to repurpose it? I'm trying to just work.
I think that would be the appropriate forum to have that discussion, because then our chief executives, our chief finance officers, and our clinical leadership teams will all be involved in those decisions.
So before I turn to other colleagues, I know others got their hands up, but Mary, would that answer your question of pace?
Yeah, thanks, John. I am assured by what you're saying, Susan, and I know what people do is very difficult, and I completely accept that everybody is working their hardest. I think it is just quite hard sitting around the table knowing that we're still not making that sort of leverage on some of the problems that we've got at the pace and in the way that we would like, and without making any kind of separatist claim, one of my difficulties is it sits right in front of my eyes every day. And I know we all know this, but people sitting in our wards who shouldn't be there is a very distressing thing for us as a system to have to contemplate, because their lives are much less than they could be. And I know if Kate was here, she would be saying, we want everybody to live to their absolute full. We do. And at the moment, we're not doing that.
I don't disagree with you, Marion. That's something that we revisit.
So what I'm going to ask to be minuted, if that's all right, before I bring others colleagues in, because I don't want to butterfly and lose this point. It's a critical point. SEG is Friday next week that you're talking about the decision?
Week tomorrow.
All right, week tomorrow. Can I therefore ask whoever chairs that, who chairs that meeting? Okay, so when Kate's back, can we collectively agree that Kate, on behalf of SEG, will share the outcome of that? So with this group, so that we can know what the decisions have been taken before we have to wait for the board meeting on the 14th of March. Is that acceptable, particularly to chief executives I know are sitting there as well? Is that okay? Is that okay?
Yeah.
Lovely, thanks. So I'll move on. So I think it was Rachel next.
Thank you. I was just on Ali's behalf, because she's not here today, that the council, in supporting any sort of in-year work around the flow and discharge, I think Rachel Rothrow will be the lead in supporting. I know you work with her closely, but obviously part of this is around making sure that the direction of travel with the social care market is aligned and supportive. So, obviously.
Thank you for raising that. In fact, I spoke to Kate Canally this morning. I don't know if she told you. And I've dropped a note or spoken to Steve this morning about it too, in terms of if the group want to go down a particular route in that space, that Rachel Rotherrow is the go-to person, and Rachel Rotherrow will keep Kate Canali involved on what the decision is from SEG. Okay. Bear with me, I'm getting slightly old and I've forgotten. Debbie was next, and then we're going to go to Emma.
Thank you. So I guess I just wanted to shift the conversation slightly, because the other thing that we're really needing to look at now are what pressures are we going to continue to face in Q4. So having described some of the discharge challenge that is collective to us with bedded provision, so CFT, RCHT and UHP, we know that we tend to see a reduction in packages of care during half term. And I know we always roll our eyes and say, well, we should plan for that. And it happens 3 times a year, and school holidays happen 3 times a year. But that is always, Susan knows this of old, we see a slowdown in the number of domiciliary care packages and packages at home. So we're imminent for that. And then, of course, we've got Easter. So we're going to need to make sure that whatever plans are in place for winter stretch into Easter, because a lot of those winter plan schemes, the funding ceases for those, as I understand it, on the 31st of March. And so therefore, some of these schemes that are successful have not got sustainable funding going forward. And if I look at page 30 of this report, Chair, it references under strategic intent against an expectation of and planning for flat cash. And I'm not quite sure what that's saying, but it infers to me that some of the things that we may have stood up, there's an expectation that they continue as a result of improved productivity rather than discussions around non-recurrent funding. So that's not for resolution here today, but I just want to flag that I think SEG is going to need to also be thinking beyond the end of Q4, or giving a really clear decision.
We're going to note that. In fact, can I ask Molly, can we minute that that's actually a key dynamic to this? Emma?
It was picking up on Rachel's point, actually, again, to offer the work of the VCSE in supporting discharge and making sure that that's an embedded part of the discussions around the revision of the winter plan, to see whether or not there's anything additional we can do.
Okay, thank you.
That's really helpful, Emma. And we've again, that's another example of iteration. So the work that we're doing with the reablement team has been really successful with humans and chaos involved in that, in bringing people in P1 out of hospital in a really safe way that's been well received. So thank you.
So colleagues, I'd like to wrap up now and move us to the ask here is to receive and note the report. Well, I think we've moved beyond the report in that discussion, which I think was important. I think we've now got some minuted actions that we're all happy with.
Thank you.
So just before I finish, I want to thank you for that discussion, because this is so critical and it's so system orientated that the answer to this exam question is requiring all of us to do our bit in that. And therefore I'll be looking towards the clinical group next week and SEG to reappraise and not reset, but recalibrate the winter plan and the spend accordingly. And like I say, you'll let us know at the end of Friday of next week. Lovely. No, thank you very much, everyone. Okay, so let's move on to item 11, which is in-year scorecard. Molly, we are in your hands.
Thank you, Chair. So attached to the appendix to the report is a sum total of the in-year risk position, which has been considered by the committees of the board that aligns those risks. And the board is asked to note the content. It's worth highlighting that we're going through a risk update process in advance of the end of the financial year. And the aim is to bring back the updated in-year risk and the BAF position at the April meeting. And in terms of progress and updates, I think Martin mentioned that the audit committee met last week. And as part of that meeting, I just would like to add that we did actually also consider the role of the audit committee, and we proposed to the audit committee what that role would entail, and that proposal was accepted. And that proposal will inform the development of the risk strategy, which will set the framework for how risks are monitored across the committee and governance infrastructure underneath that, as well as at board. So I think it's worth highlighting that particular point. And then also within the paper in section 2, there is an update which reflects the fact that several controls remain assessed as partial. Whilst they may be in place, they are still embedding or developing, and there's a need for us to gain strong and consistent evidence of their effectiveness. And then turning to Appendix 1, I think the board will agree that there's some elements of risks we already talked about today. So most of the performance ones will be familiar to board colleagues, having been covered within the IPR. But nonetheless, we, as part of the year-end cleansing process, will go through the IPR and make sure that we triangulate areas of non-performance with risks and provide the assurance as part of the year-end update position. And similarly, we've talked about the financial risks and the break-even risk position as well, which, as we know, is dependent upon confirming the funding for industrial action, amongst other things. And we do have some risks as well around quality, and members will see as well in the appendix that some of them are under development, but the Quality and Pathways of Care Committee have specifically reviewed them and asked the corporate governance team to work with colleagues to ensure completeness and alignment to our quality risks and areas of concern. So at the next update to the board, we'll be able to provide that assurance, having gone through quality and pathways of care. And similarly, we did go through a risk update at the Workforce Committee in December, which will inform again the development of workforce risks. So I'll pause there, Chair, and just see if there's any specific questions about the detail from the appendix or the content of the paper.
The risks? Happy for me to receive the in-year risk, principal risks and underlying corporate risks as in Appendix 1? Yeah? Rachel?
Just a quick comment on the sort of scale, the likelihood ratio. So the maximum risk is 20. So just on the risk, all of there's a lot of 20s. So it's just a question about proportionality and whether that's appropriate.
Yeah, I thought that when I first read it. So because one person's 16, another person's 20, kind of thing. So can I just ask, Molly, from the central corporate governance team, are you having the central author view, or is this being all led by other teams, all thinking their red is more important than somebody else's red?
Thank you, Chair. So I probably should start by explaining that the highest risk rating we can have is 25. So this is the current rating of the risks after the application of controls. So in keeping with the fact that these are exceptional risks, we've picked out the risks that are mostly rated the highest following the application of controls. And in answer to your question, the risks are owned by the leads that are more specialised in the subject areas. But having said that, we're actually going through a check and challenge process that will allow us to understand whether the risks are consistent with our understanding of other triangulated sources of data or information. So we may actually find that some of the risks are going down, but equally, I think it's worth noting that there may be some risks which are not included here, which are too low. So we'll also include that assurance in the next update.
And also if it's before or after mitigation.
Yeah, I agree with that point too. Can you capture that? Because that's important. The one thing I was going to tease out on this, and it's only my view, but in order to help the board focus on quite a long list of this, I'm just wondering. I mean, I sense from all the papers that I've read and the discussions that I've had that if you park the money for one side for a moment, elective and discharge are two of the absolutely critical things for us to collectively sort out. I know we've talked about that before, but personally, I would like to see how we support each other in the agendas and the risk registers that we have to actually say, well, how do we spend more time talking about those two key areas if you'll be more prepared to do that? It just seems to me that those are immediate and imperative. Would that be a reasonable request to add? Mm-hmm. We had our away day and we spent a lot of time talking about priorities and that kind of thing. I'm just trying to get us to focus rather than on what feels like 20 or 30 of them, is that we might actually sort of say, how do we swing the pendulum a tad towards our top priorities and at pace, Mary, get clarity on what we're doing on those and everyone's signing up and doing their bit in it? Would that work for everyone? Yeah. So Molly, if you could take that away, I'd be very grateful. Okay, so I'm going to note that we've considered the in-year principal risks underlying the corporate risk register as in Appendix 1. Okay, so what's the time? Gosh, we're a minute out. I do apologise. So let's move to the forward plan. Now, Susan, I think this is a good example where, particularly when Kate gets back, we're going to, as a group, just have a conversation again about papers and timeliness of those and then coming through. So it already starts with here. So can I just ask for the part 1 public session next time, if we know these are the papers that we want to have, there might be a few that creep on afterwards because there normally is, but if we know these are the vast majority of the papers that we want to have, there's no reason why the executive group can't start tomorrow in terms of a paper planning for that. So I will ask you just to spend 5 minutes just gazing down, and then I'll turn to the executive group, if I may, and say, are you happy with these? I mean, you wrote them, so you must be. But I just want you to verbalise that here, if that's all right. So just take a look, and if you think there's anything for part 1 next time. It seems an awful lot to me, is my observation.
March looks like a very meaty.
Yeah. I mean, I'm not, how do you dumb some of it down? But I do think whether there might be an option as to whether we could delegate some of these down to committees that actually do, Steve.
Well, I was just going to suggest that perhaps we don't take committee chair reports, partner member reports. There's an item on the agenda for financial recovery update 23-24 that could potentially drop out because we'll be at the end of the year anyway. So I do think there are a couple of items on the standing agenda that could be removed without an impact on the focus that the board would bring.
Yeah. Molly, will you take that away and work with the executive group to take that? I really feel less is more next month, and we ought to carve out, particularly on budget and on quality, and almost say, I'm going to just pluck a number to be helpful, just to give you a direction of travel. We should be spending 80% of our board time next month on budget issues and quality issues, and then see what we can fit in the rest. Does that feel like a sensible mix? Yeah.
John, just from a perspective from PCCC, the dentistry update is really important, and I think in terms of what's going on nationally as well, it's going to be quite important that we do have something on that.
All right. Okay. Debbie?
Just clarify with Carolyn, because this is under your name, the joint forward plan, will that be the draft of the operating plan that goes alongside the budget sign off?
So that's our 5-year refresh that we've got to do. So they are similar, but they're not the same.
They're not the same.
No.
So I actually feel, Chair, that it's quite hard to sign off the budget if we're not also signing off the operating plan, because although the operating planning guidance has not yet been published, we have been asked to plan for at least improvements on what's in our SOF, and we know that there are mandated priorities. If you take mental health, for example, it's the final year of the long-term plan for mental health. So I think this board should rightly understand the interface between the financial plan and the budget for next year, and how that interfaces with our operational priorities, and how that has been achieved in a flat cash environment, because there's a huge amount of work to be undertaken between now and that meeting, John.
So that's what I'm going to do then. Oh, go on.
Can I just respond? So you're absolutely right, Debbie. Obviously, the joint forward plan and the operating plan are similar, but they're not the same. And because the joint forward plan is just a refresh of our plan as it is, the narrative that will support the operating plan should be ready at the same time that Simon is bringing the 24-25 budget. So I would suggest they come side by side, because they will go in side by side.
Thank you. Can I ask Rachel?
I think I've just, to reiterate, I think there's a requirement that the board sees the submission that goes in on the 21st of March. So I agree with both those comments.
Well, I'll go slightly further. I would like to think that on the 7th of March, the board papers that go out on the 7th of March actually have a worked through budget for 24-25 for sign off on the 14th of March's board meeting, because we only have a matter of days then to actually formally sign it off on the 21st of March. So I would like to actually get to the point where we actually treat a 3-week time. I'll get to it, Sanj. Yeah. I would like us to try and treat a 3-week timeline from today to try, because that's how long we've got between now and the 7th of March, that we ask the chief execs and the CFOs and their colleagues to actually work to ensure that we have a paper ready for the 7th. Sanj?
Just 2 comments, hopefully helpful. We've got strategic dentistry update in March, and we've got in-year dentistry update the following month. And I just wonder whether there's a way to combine those to be more efficient. Particularly the in-year dentistry update is literally in month 1 of the new year. The second point was recalling something Myri suggested, which I supported, which was to put in placeholders for additional meetings of ICB and perhaps FBCC to sign off the budget in March. Whether we need it or not, it's better to have it in the calendar, and whether that can be done based on your comments, John, that whatever might be needed to be done between March 7th and March 25th.
Okay, so can I just be really clear? We did talk last time about an extraordinary board meeting in March. Is it the 20th or the 21st? Because it's still not in my diary.
We spoke about the 20th, and you're just finalising, Chair.
Right. So can we collectively agree now that we'll have an extraordinary board meeting on the 20th of March, which is a Wednesday? Okay, for those who can attend, I get that. All right. But what I'm trying to get at is that, can I also ask then, is it reasonable then to actually ask, given you need the budget with the operating plan that needs to be supported by the clinicians and everything else, can I ask the chief execs and CFOs, can we work towards the 7th of March to actually have that budget paper in advance? Because if ever you needed time to read and consider the implications, it's going to be this. So Steve and Debbie, you all right with that?
It's just a fundamental comment. So yes, we need a plan for that timing. So agree entirely with that. The only issue for me, which people be aware of, is the latest view on when our formal planning guidance comes out is the eve of the budget, which is about the 6th of March. So, but we will just have to work with what we've got and take account of that. Yeah.
Let's assume that's an enter stage left debate as opposed to anything. Yeah, Debbie.
So just a note.
So I agree with the timeline that we're beginning to scope out for this, but I'm just aware that we've got a first draft going in on the 29th of February. Have we not, Simon?
Yes, there is a first draft. In terms of how complete it is still under question.
So we would want to probably see at board what went in, and then the movement from that, because we'll know, as Simon says, some things will be unanswered. But also, if we're looking at this in early March, there may be some, rather than this board signing off plans that have already been baked in. I know you've previously said it's very helpful for the board to be cited on options, because there may be some prioritisation or least worst option discussions to be had.
Yeah, that's a fair challenge. No, to be fair, what I meant was there'd be a pack ready to go out. I do apologise.
Yeah, sorry.
That might actually have options or whatever, but whatever they are. No. This is so important. I think it's important that we have a week then to read, digest, socialise, debate, and that kind of, and then continue the debate in here, kind of thing. So we're going to agree the 20th. I would like maybe Mary and Margaret to get your thoughts on whether you want to vocalise it now or later, how we do this, because something for me about the rhythm over a 3-week window, and that might be asking the chief execs to meet, I don't know, daily, that we all meet with the chairs weekly, or so, I don't know whether you had any thoughts you'd like to add in now or talk about it later. I don't mind.
That sounds like a really sensible plan. I'm just really aware of the burden on everybody involved. So I guess if that's a proposal, would it be helpful or otherwise is the question. But certainly I'd be happy to take part.
Can I just ask, Margaret, what would you feel? You're fine. Thank you for that. Thank you for that. Steve?
Just mindful as well that in the private section, there'll need to be some conversations around budget preparations as well, and whether we come back to this question
I agree.
in terms of the interim oversight, which I think would be helpful, but we can perhaps finalise that. In the
I just thought, bearing in mind we have members from the public as well viewing how we're doing things, that we are setting out to the public too an expectation that we will be ready. We will find a way of working, which we will discuss later in part 2, the how. I just wanted to give the impression to all of you and to everybody else that we will find a way. Yeah. Okay. Right. Have you got enough out of that, Carolyn and Susan and Molly out of that? So could I ask on the forward plan, you have your meeting on Monday with the executive group. Could you revisit that?
Yes, we will.
And then could you make sure no later than Friday of next week when you get to SEG that you collectively as a group at SEG have agreed what's on here? Because I think then everybody knows what papers are coming, everybody is clear on the timelines for it, and we can all work towards getting those out in advance on the 7th. Very good. Thank you very much. So we've got we'll move on to, are there any questions from the public? So I'll pause for a second. Yes, there is. Sarah Barker, please ask your question.
Hi, it's probably a stupid question, but I was wondering if the acute care at home could be expanded so that it takes pressure off hospitals and things.
Very much. Who would like to answer that? Do you want to go to Steve or?
Do you want Debbie? It's Debbie's service.
Oh, Debbie, I do apologise. You'd think I'd know by this time, wouldn't you?
Question. From your question, I'm delighted to receive that, because we do know that our acute care at home team are able to provide home antibiotics and infusions for patients, which means that they in the care of their own homes. So it's a specialist nurse service, and it means that we can get people home much more quickly from Derriford and from RCHT and on occasions from our own beds. It is a peripatetic service, so it means that our staff are in 2 teams in the county because of the specialist skills required and the number of different procedures that then are undertaken. So they have to be undertaken in a way that's clinically safe. So it's something that we can plan to expand, but we would need to do a demand and capacity analysis with our partners to actually note what the demand would be for those different services out there in the community, and plan and ensure that we've got trained staff accordingly. It is something that we keep under review, and we do know that it is extremely popular and welcomed by those who are in receipt of that service.
Okay. Thank you for the question. Thank you for the answer as well. Any other questions that would like to be asked? No? Okay. Thank you very much. So we've done that. So I'm going to close the meeting at 4 minutes past 12. Thank you very much, everybody, for that. Thank you very much, everyone, for this morning. Thank you.